Dr. Kamran Siddiqui, we're waiting for your lecture.
Done, sir.
Thank you very much. Assalamu alaikum and good afternoon, everyone. My name is Kamran Siddiqui. I'm a professor in global public health, trained as a chest physician. I now focus entirely my research on tobacco control. And today I'll be talking about tobacco and non-communicable diseases as an important area in the conference. Before I begin, I would like to disclose my funding sources. Over the years, I've been very lucky to receive a number of research grants from public interest bodies. I've also received some industry funding from Pfizer to conduct a randomized control trial, but I've never received any tobacco industry funding, nor I have any plans to receive any tobacco industry funding. So let me start with with non-communicable diseases. Non-communicable diseases are responsible for the majority of deaths in Pakistan. These are the figures from 2019, and all these boxes represent the deaths in Pakistan. And as you can see, the majority, actually 55% of deaths, are because of these blue boxes. And blue boxes represent NCDs. Cardiovascular diseases, neoplasms, diabetes, chronic respiratory diseases, and so on. And the orange or red boxes represent infectious diseases, and the green boxes represent accidents and violence. And within these NCDs, a fifth of all NCDs are due to tobacco use. Right. The thing about tobacco use is that it's totally preventable. Although it appears as number 4 among all the other risk factors for NCDs, high blood pressure as number 1, dietary risk factors as number 2, air pollution as number 3, and tobacco as number 4. This is for Pakistan, by the way. Although it appears as number 4 among all the risk factors, but if you compare it to the other risk factors, it's 100% preventable. And for all these 150 deaths that happen, NCD deaths that happen because of tobacco use, they should not happen, because there are, you could just not use tobacco. But of course, it isn't as simple. So what is the burden of tobacco use in Pakistan? For an individual, if somebody smokes and continue to smoke after the age of 30, they lose about 6 hours of their life every day. So every day, 6 hours of life are lost because they continue to smoke. Within a year, this becomes 3 months. So a quarter of the year is lost. And over a lifetime, in a lifespan, a smoker will lose 10 years of their life. So this is the cost. This is the life years lost due to tobacco use. How common is tobacco use in Pakistan? More than a quarter of men in Pakistan use tobacco, and that is not just smoking, it's also smokeless tobacco. While smoking is less common while smoking is less common amongst women, smokeless tobacco is more common, and still 1 in 20 women use some form of tobacco. Perhaps these figures are not, they're a little bit underestimate, because there is a stigma associated with women using tobacco, and therefore these figures may be less. Very worryingly, a lot of boys and girls are using tobacco. 11% of boys use tobacco, and these boys are 13 to 15 years of age. And again, the girl use is increasing of tobacco use among girls, and that's also 13 to 15 years of age. So what is the burden? In terms of the life burden, 160,000 deaths every year, 160,000 deaths occur because of tobacco. And out of those 160,000, a vast majority of them are because of tobacco, because of NCDs. In terms of the economic loss, this is a recent study from Pakistan, that we lose 615 billion rupees every year because of tobacco-related diseases, 615 billion rupees. Now, you must ask yourself that actually tobacco also contributes to the tax. So how does that compare with the tax? So every year, tobacco industry pays about 120 billion of tax income. So you can clearly see that the loss of money from tobacco is 4 times higher than the money gained from the taxes. So clearly, this is not a business that is in the profit, even if you remove the health cost or the number of deaths. Purely economic reason, this is not a good business for Pakistan. So now I'm going to turn to my talk on gaps and opportunities, and I'll focus on 2 gaps, treatment gap and policy gap. What do I mean by treatment and policy gap? By treatment gap, I mean that to help those who are addicted to tobacco. It's all very good to say that don't use tobacco, but those who are addicted have got a high level of dependency on tobacco, and therefore it isn't easy to stop its use. So what is the gap here? And then I'm going to talk about the policy gap, which is to prevent uptake of tobacco, especially in youth, and protect non-smokers from secondhand smoke. So let's turn to treatment gap first. This is perhaps one of the most important slides in my presentation today. What it shows is the treatment gap. These figures are taken from a survey of smokers in Pakistan. So when smokers and tobacco users were asked in Pakistan whether they have visited a health worker in the last 12 months, 40 to 45% of people said yes, they have visited. But when they were asked that whether the health professional inquire about their tobacco use or given advice to quit or any treatment to quit, very few people actually said that yes, they have been given advice. So what does that show? It shows that while almost half of the smokers and other smokeless tobacco users, they visited a health professional, but minority of them were actually given any advice to quit. So if you turn all this gap into an opportunity, imagine how much good can be done only if health professional, every time you see somebody, an adult, and you ask that whether they use tobacco, and if they use tobacco, then advise them to quit. That is a very, very effective intervention, by the way. Even before giving any medication or any long counseling, just a doctor advising somebody to quit is highly effective and highly cost effective. And look at the opportunity that is missed. We are worried about their treatment. We are concerned about a lot of things, but we don't ask about tobacco use and whether they are like to quit or not. So this is the gap. And this can be addressed if all health professionals from today start asking their patients about their tobacco use and advising them to quit. Turning to chronic diseases and NCDs, smoking prevalence is higher in a lot of chronic conditions, NCDs, compared to general population. If you look at mental illness, the smoking prevalence is almost double than general population. In people with chronic obstructive pulmonary disease, it is also about 1.4, 1.5 times higher. In asthma, I know in diabetes, it's a little higher as well in general population. So clearly, the smoking prevalence is higher in people with NCDs than in general population. What is more important to know is that smoking cessation actually improves NCDs. And I will give you a couple of examples. This example is on chronic obstructive pulmonary disease. Smoking cessation actually is the only treatment in chronic obstructive pulmonary disease, the only treatment that reduces the progression of the decline in lung functions. So as you can see here, that over the years, the lung function declined with age. This is a never smoker. This person, lung function declines. This is somebody with COPD. Their lung function declines quite rapidly, as you can see. But if they stop smoking at the age of 50, the decline actually reduces. Even at the age of 65, their decline reduces. I don't know if any other treatment of COPD that can actually reduce the progression of the disease or reduce the decline in lung capacity. but smoking cessation has. Similarly, in cancer, our tendency is that if we see somebody with a cancer, we say it's too late. This person has already developed lung cancer or mouth cancer, and maybe there's no point in asking them to stop smoking. Actually, there is a point. Even if they quit at diagnosis, their risk of dying is reduced by 11%. And that adds about 1 year to their life, 1 year to their life. Now, somebody with a cancer, we give very, very expensive chemotherapies just to prolong their life for 6 months or 1 year. This does not cost anything. This only costs an oncologist or a health professional to advise somebody to quit, even if they've been diagnosed with cancer. And that can actually give them an extra year in their life. This is people with cancer. So what happens when people quit? In case of COPD, their mortality rates decline and their oxygen-related accidents also prevented. In case of asthma, their symptoms improve and quality of life improves and the medication need is reduced. Now, most doctors think of quitting as this single event, that somebody was smoking, one day they decide, and then they stop smoking, and then everything is fine. So this is a very physician's view of quitting smoking. So I just wanted to show you one slide to show the real smoking cessation. And this will help us to think about when we look at our patients. This is the real world quitting. A lot of people smoke. This is the category of smoke. They smoke as usual. Then they decide that they should quit. Then they reduce their smoking. Then they go back and start smoking again in the same numbers. Then they stop. Then they go back. So this is a continuous process. It's like a chronic disease, tobacco addiction. It isn't a single event. And just like any other chronic disease, physicians have to work with somebody. So it is, again, our tendency that we advise somebody to quit. If they don't quit, we think that's no longer important, but actually it is very important that we work with colleagues, work with individuals to advise them and to support them in quitting. There are many treatments other than just simple advice. There are many treatments. There are group therapies. There are individual behavioral therapies. There's telephone support. There's text messaging. So all of these work, but clearly behavioral counseling works best. And there are other treatments as well. These are available in Pakistan. Varenicline, which is very effective. It helps to quit quite a few patients, and similarly nicotine replacement therapy. If you use dual form of nicotine replacement therapy, like a patch and a gum together, that is more effective than single form. So all these treatments work, and they're good. So in patients with NCD, how can we address this treatment gap? We can address, because higher smoking prevalence occurs in NCDs than general population. They have worse outcomes if they continue to smoke, and they respond better to smoking cessation than general population, and that improves their mortality and morbidity if they quit, and effective treatments are available. In the last 5 minutes, I'm going to turn to the policy gap. This is very, very important. The price of a 20 cigarette pack in Pakistan is from rupees 48 to rupees 130. Pakistan has got one of the cheapest cigarettes. The price is lowest in Pakistan, and cigarettes are highly affordable. In fact, according to WHO, cigarettes have not become less affordable in Pakistan over the years. Now, in order to make cigarettes expensive and out of reach of young people particularly, WHO says that the excise taxation should be 70% of the retail price, 70% of the retail price. But in Pakistan, unfortunately, it is only 36% of the retail price. So why there is such a gap? Our Prime Minister is a strong advocate for tobacco control. So why we still have not been able to increase tobacco taxation and make cigarettes more expensive and out of reach of young people? That is because of heavy interference from tobacco industry. Pakistan scores 66, very high on tobacco industry interference index. They participate in our policy making. There is corporate social responsibility that gives a positive image to tobacco industry. Government often gives benefits to the industry. There is a lack of transparency. There's conflict of interest. A number of civil servants, when they retire, our deputy secretaries and additional secretaries, when they retire from their jobs, they join the board of tobacco industry, and that helps them to navigate their way into policy making. And then unnecessary interactions. WHO says nobody should interact. No government department, not just health department, no government department should interact with tobacco industry. But that is not the case, unfortunately. And that's why we have so many gaps. There's no requirement for any contents of tobacco on the labels. We have also no tracking and tracing system of taxation in Pakistan. And if you compare smokeless tobacco with smoking, there's even less. There are no warning labels on smokeless tobacco. There's no requirement actually of warning labels. There's also an implementation gap. For example, we have smoke-free laws, smoking bans, but 40% of all pregnant women in Pakistan are exposed to secondhand smoking. This is our research, which leads to 17,000 stillbirths. So although smoking is less common in Pakistan amongst women, but their husbands and their other partners or other adults are smoking around them, and that causes a lot of problems. And similarly, despite a ban on sale on loose cigarettes, 30% of cigarette consumers are loose cigarettes, and they pay less than the minimum price. But there is a big opportunity. Smokers think, and this is a survey among smokers, most smokers think that they should ban smoking or increase the age of smoking or increase tobacco taxes on smoking. So that's great, because a lot of smokers actually support strong policies against tobacco. So what should we do? We should stop tobacco industry interference. Tobacco-related CSR activities, that is, corporate, should be banned. There might be a register of all industry representatives. The government should require the tobacco industry to submit information on contents, and there should be a code of conduct for all civil servants for interacting with tobacco industry. There should be a higher tax on tobacco. The WHO threshold of 70%, I think, should be reached. In the short run, the two-tier system, the taxes should be increased, but in the long run, the two-tier system should be abolished to have a single-tier system. And we should offer smoking cessation support wherever it's possible. Continue to introduce ban on smoking in private cars, and plain packaging should be introduced. We should increase the age of purchasing and selling cigarettes up to the age of 21, and introduce vendor licensing to enforce bans on selling loose cigarettes and cigarettes to children. And we should make tobacco control laws very comprehensive to cover smokeless tobacco as well. And in the end, I'm going to leave you with this slide that I've been talking about tobacco control, but actually the principles of tobacco control can apply to other areas as well. So these principles are transferable to also sugar industry. We can also raise taxes on sugar that can reduce obesity and diabetes. And there are many other examples. These are some of the references I've used. I thank you very much for listening. And if there are any questions, I'll be happy to answer them in the end.
Thank you, Dr. Kamran. That was a very nice lecture. And our next speaker, very happy and honored to invite my friend and colleague, Dr. Shahid, who is not just a doctor of medicine, but also a doctor, PhD doctor. He'll be talking to us.
आर्यन देखता है ये सब कुछ अच्छा मुझे फर्स्ट टाइम इन्होंने डॉक्टर अब्दुल बासित के साथ
Assalamu alaikum, ladies and gentlemen. Topic of my discussion today is I'll discuss today metabolic diseases and obesity. Obesity is a complex disorder of multiple etiologies characterized by excess body fat that threatens or affects socioeconomic, mental, or physical health. There are three ways to assess obesity. BMI or body mass index is used to assess generalized obesity, and waist circumference and waist to hip ratio to assess central obesity. Central obesity is more important as a risk factor for diabetes, heart disease, and other metabolic abnormalities. According to WHO criteria, BMI 25 and greater depicts overweight, and BMI more than 30 means obesity. Due to higher metabolic and cardiovascular risk, the BMI range for Asian population differs from the rest of the world. For us, the overweight category starts from the BMI of 23. ये echo हो रही है वहाँ? Sound ठीक है? And for us people from Asia, overweight starts from the BMI 23, and from 25 kilogram per meter square, obesity starts. And then there are three grades of obesity: class 1, class 2, class 3. Undesirable waist circumference differs from men and women. Men are at risk who have a waist measurement greater than 102 centimeter. This is for all the people, and for Asians it is 90 centimeter for Asian men and 80 centimeter for Asian women. So criteria is very strict for us. For both men and women, a waist to hip ratio of more than 1. It means that waist ratio is greater than the waist hip circumference is greater than the hip circumference. It means there is more central obesity. So waist to hip ratio more than 1 is called apple shape body shape, and when waist circumference is less than hip circumference, this is called pear shape body shape. So apple shape is bad, pear shape is okay. Obesity is not because it runs in the family, it is because no one runs in the family. It's an internet joke, not totally true, because obesity has a genetic component. It's a multifactorial problem. It has a genetic component, but environmental and lifestyle factors are more important. The fundamental cause of obesity and overweight is an energy imbalance between calories consumed and calories expended. Globally, there has been an increased intake of energy-rich foods that are high in fat and sugars, and an increase in physical inactivity due to the increasingly sedentary lifestyle, changing modes of transportation, and increasing urbanization. Worldwide, obesity has nearly tripled since 1975. According to WHO estimation, in 2016, more than 1.9 billion adults 18 years older were overweight of these, over 650 million were obese. 39% of adults aged 18 years and over were overweight in 2016, and 13% were obese. Over 340 million children and adolescents aged 5 to 19 years were overweight or obese in 2016. Situation is even worse for Pakistan. According to this National Diabetes Survey conducted by Professor Basit and his team in 2016-17, prevalence of generalized obesity in Pakistan, this is according to the Asian criteria. Prevalence of generalized obesity in Pakistan is 57.9%, and prevalence of central obesity is more than 70%. Prevalence of generalized obesity in different provinces of Pakistan is almost the same, and there is a marginal difference between rural and urban population. So a generalized problem. And prevalence of central obesity in Pakistan is also same in all the provinces, and there is marginal difference between urban and rural areas, except that in KPK rural area, it is central obesity is slightly less. This is a very good study conducted by Professor Basit and his team, and they measured metabolic abnormalities in children according to their arm fat percentage. And they noticed that the children with highest, green is the children with highest arm fat percentage. That they noticed that the children who had high arm fat percentage, the total cholesterol was high, triglycerides were high, LDL, which is a bad cholesterol, that was high in those children. HDL, good cholesterol, was low, and there was marked insulin resistance and hyperinsulinemia in those children. Hyperinsulinemia and high insulin resistance means that they are liable to develop diabetes in near future. 9.6 million children in Pakistan are overweight and obese, and a study on 8 to 10-year-old children of Karachi showed that 9.8% were overweight, 4.3% were obese, 80% had a habit of poor intake of fruits and vegetables, and 40% of the children, they had a habit of consumption of aerated sweetened drinks and fast food daily. Obesity affects almost every organ of the body. मैं अपने पेशेंट से ज्यादातर ये कहता हूँ कि बीमारियों से मोटापा नहीं होता, मोटापे से बीमारियां होती. Patients usually think that I have some endocrine problem or some other metabolic problem and I'm getting more and more weight, but this is not the case. You do get some weight gain with hypothyroidism or steroid excess, but mostly it is the obesity first and the other problems, they appear later. So starting from the brain, obese persons have increased incidence of stroke, then degenerative diseases like Alzheimer's and Parkinson's disease, pulmonary disease, obstructive sleep apnea, hypoventilation syndrome, then coronary artery disease, diabetes, lipid disorders, hypertension, fatty liver, which may lead to steatohepatitis and cirrhosis, which is an end-stage liver disease, then gallbladder stones, pancreatitis, increased risks of cancers like breast, uterus, cervix, colon, esophagus, pancreas, kidneys, then infertility in female and infertility in female both. The commonest cause of infertility in female is polycystic ovarian syndrome, which is due to obesity. And in males, there is low sperm count and poor motility of sperms due to obesity. Then osteoarthrosis of degenerative disease of the joints and lumbar spine, then varicose veins. All these problems are due to obesity. Similarly, in children, there is depression and low self-esteem, increased risk of heart disease, blood pressure, stroke, gastroesophageal reflux disease, sleep apnea, uh, increased incidence of, we are seeing more and more children with type 2 diabetes now, then gallstones and problems with early puberty, metabolic syndrome, polycystic ovary syndrome, etc. Pakistan is among the top 10 countries in terms of obesity, with individuals at a high risk of metabolic disorders or metabesity. Metabesity is a relatively newer terminology in medicine, defined to cover different metabolic diseases under one caption. It includes obesity, metabolic syndrome, diabetes, cardiovascular diseases, neurodegenerative disorders, and accelerated aging. Screening for metabesity includes screening for cardiovascular diseases and lipid abnormalities. Adult patients at risk must be screened every 5 years with lipid profile. Annual screening is recommended for older patients, and for obese children and adolescents, these tests must be performed after every 3 years. Screening for diabetes is done with the A1C measurement is a primary screening tool, and A1C levels above 6.5% is diagnostic of diabetes. It is reconfirmed with fasting blood glucose or 2 hours after 75 gram glucose. Then screening for fatty liver is done with liver enzymes and ultrasound of the abdomen. Then screening for cardiovascular conditions, cancers, and other disorders may be performed as recommended after a confirmatory diagnosis of metabesity. The components of metabolic syndrome are waist circumference more than 90 centimeter in men, 80 centimeter in women. Fasting glucose more than 100 milligram deciliter, that is impaired fasting glucose, or the patient has already type 2 diabetes. Patient has a high blood pressure greater than 130 by 85 millimeter mercury on 2 different occasions, or a known case of hypertension already on medicines. Patient has triglycerides above 150 milligram per deciliter, or HDL cholesterol less than 40 milligram per deciliter in men and less than 50 milligram per deciliter in women. Metabesity or metabolic syndrome is diagnosed when 3 of the above criteria are met in obese persons. Treatment of metabesity includes lifestyle modification, drug treatment, and bariatric surgery. Bariatric surgery means weight loss surgery. Lifestyle modification comprises of dietary counseling, physical activity, and weight reduction of at least 7 to 10% from the baseline. And drug treatment, we use drugs to treat obesity, hypertension, diabetes, and lipid abnormalities. Physical activity recommendations are, these recommendations are from the National Metabesity Guidelines, which are published this year. Physical activity, moderate intensity physical exercise for 150 minutes weekly, or vigorous intensity physical activities for 75 minutes weekly. Muscle strengthening exercise or resistance training 2 to 3 times a week. And apart from these, an increase in non-exercise leisure time activities to reduce sedentary behavior in individuals. Examples include walking in the parks or playgrounds, walking to the mosques, and using stairs rather than elevators. Medical dietary recommendations include caloric deficit of 500 to 750 kilocalories for weight reduction from the stable diet at which our weight is stable. from that diet, we should reduce 500 to 750 kilocalories per day. Low fat, high protein and low carb diet is recommended. And this is for non-diabetic who are not diabetic yet. Low fat, high protein and low carb diet. Increase the intake of fresh fruits, vegetables and low fat dairy products and whole grains. Avoid the intake of high calorie and fried foods and avoid red meats and organ meats. For persons with diabetes, we do not recommend low carb diet. We recommend carbohydrates 50 to 60%, fats 25 to 30%, and proteins 15 to 20%. But these carbohydrates are complex carbohydrates from whole grain, cereals, fruits, and vegetables. And for cardiovascular disease, a regular intake of fish at least 2 times a week should be encouraged. These are the foods that must be eaten: fresh fruits, whole grains, low fat, dairy products, and protein-based food, except red meat, eggs, and lean meat. And these are the foods that must be restricted, and these are the foods which we all eat in plenty. Biryani, nihari, kadai, kofta, halwa puri, sugar and bakery products, and puri, baturas, rogri naan, etc. All these foods are bad. Now, childhood obesity is the main problem, which is a sort of a time bomb for us, because these obese children will later on develop heart disease or diabetes very early in their life. So nutrition recommendations are almost similar. Balanced dietary calories with physical activity. Physical activity for children is 60 minutes per day at least. Daily consumption of vegetables and fruits and limited consumption of juice. Children aged 2 to 3 are recommended to consume 1 cup of fruits and vegetables each daily, regardless of their gender. And children aged 4 to 8 are to eat 1.5 cup of fruits and vegetables each, irrespective of their gender. There should be a reduced consumption of sugary drinks and foods, and increased consumption of whole grain bread and cereals instead of refined grain foods. Avoid high energy fast foods and snacks, and they should have an increased consumption of oily fish, and salt intake should be reduced. This is kids' healthy eating plate. Weight loss surgery is done for severe obesity when BMI is more than 35, or even when BMI is low but patient has difficult metabolic abnormalities like difficult to control diabetes or ischemic heart disease or other metabolic problems. Recommendations for bariatric surgery includes, I have told the 35 kg per meter square. And bariatric surgery is effective in reducing hypertension and development of type 2 diabetes. There are some newer alternatives, less invasive, that is intragastric balloon placement. It can also be used in patients with severe obesity. It is a reversible procedure. Now, the take-home message, this healthy eating plate, which we should remember. Half of the plate should be comprising of vegetables and fruits, then quarter with healthy protein and quarter with whole grain cereals. So this is the healthy eating plate. Thank you.
Thank you, Dr. Shahid. A couple of years ago, America was at the top of the world for the number of obese people that it had. And surprisingly, it was taken over by Mexico, by the maximum number of obese people. And by the facts and figures posted by Dr. Bassett, we are going to soon dethrone Mexico and become the nation with the most obese people in the world. It's nothing to be proud of. We need to revisit our dietary habits and our exercise habits. And to talk about diet, we have an expert, WHO expert, Dr. Ayub Al-Jawader, and he's going to talk to us about the nutrition and how should we manage our nutrition day to day so that we do not become obese and the risk of metabesity is reduced. Dr. Ayub Al-Jawader.
Yes, Assalamu alaikum.
Alaikum salam.
This is Ayub Jawalde from WHO EMRO. I am, first of all, allow me to thank you for inviting me to participate in this important conference. And also, I would like to convey the greetings of our regional directors and our team in EMRO to the organizers and to the attendants. In fact, I'm going to talk about NCD, obesity prevention and promoting healthy diet in Eastern Mediterranean region. I'm allowed to rotate. I already shared my presentation. Hello? I shared my presentation.
Yes, we can hear you.
Yeah, I shared my presentation. I have access to...
Yes, we can see the slides, sir. Go ahead.
Yeah, but I can, yes. I'm not going to repeat the big challenge we are facing in this world concerning the NCDs. We have 41 million NCDs usually killed by non-communicable disease. And of course, 71% of all death related globally to non-communicable diseases. And I think this topic has been shared by other colleagues and the facilitators. In EMRO, in Eastern Mediterranean region, and as you know, we have 22 countries starting from Pakistan, Afghanistan, Iran, Middle East, and North Africa. The non-communicable disease are estimated to account for 62% of all death, which is almost 2.5 million. And of course, the region characterized by high prevalence of risk factors such as air pollution, tobacco use, unhealthy diet, and physical inactivity. I'm going to link, of course, non-communicable diseases with the nutrition situation. As you can see here, they have highlighted the top human risk factors globally, and they found that malnutrition and dietary risk are the top threat to the world. And of course, followed by high blood pressure, tobacco, and high fasting plasma glucose. And as you can see here, if you want to make a difference, or if you want to improve the NCD profile in each country, you should pay more attention also to the healthy diet as well as to nutrition. And just to let you know that malnutrition especially affected the stunting, and kids who are stunted are most likely to become obese. And as you can see here, the trend in our region is going up. Except for children under 5, we have been working with member states to promote exclusive breastfeeding and continuing of breastfeeding after 6 months up to 2 years. And as you can see, despite terms of number is increasing, but the percentage somehow decreased from 6.2 to 5.8. And here I would like to stress that prevention of non-communicable diseases and obesity started from infancy. So it's very important to pay more attention to the child nutrition and also to the infant and young child feeding practices, because shifting to complementary feeding with high carbohydrate and poor in protein most likely affect the child and become obese. Again, if you look at other age groups for adolescents, the same thing, it has been increasing, and almost around 25% of the region suffering from obesity. Here, I would like to highlight about the policy option, what WHO is doing at regional level. We have developed a non-communicable disease framework of action, and this framework of action, it focuses on 4 areas of intervention. The first area, governance. So it's very important to have high-level coordinated body within Ministry of Health or at national level. We should have also multi-sectoral committee to look after all sectors and to coordinate the work. And the second area, prevention and reduction of risk factors. One of the cost-effective intervention to reduce, of course, non-communicable disease, breastfeeding number 1, and also reduce trans fatty acid, reduce salt, also control or promote or control food marketing to children, especially unhealthy one. And again, for surveillance, monitoring, and prevention, very important to focus on data and try to generate a monitoring system to monitor the situation in the country. And the last intervention, healthcare, where, of course, secondary prevention as well as the intervention at health facilities are important. When we talk about non-communicable disease, we have to address Sustainable Development Goals 3.4, which stated that by 2030, reduce by 1/3 premature mortality from NCDs through prevention and treatment, and to promote mental health and well-being. Not only this, when we talk also about SDG 3.4, we talk about 5x5. And here at the left side, you can see unhealthy diet, one of the major causes, tobacco use, physical inactivity, harmful use of alcohol, air pollution. And at the right side, mental health, heart disease, cancers, diabetes, chronic respiratory disease. And those should work together in one package and one national strategy. Again, when we talk about nutrition and it is related or relation with SDGs, Sustainable Development Goals, of course, there is standalone SDGs for nutrition, SDG 2, but also SDG nutrition also contribute to SDG 3, good health and well-being, and especially when we talk about maternal and child health, non-communicable disease, as well as communicable disease. But again, nutrition contributes to the rest of the SDGs when we talk about education, about health aspects. WHO developed the global monitoring framework on non-communicable disease, and those tools are available online. You can reach them, and they have set up global targets for non-communicable diseases. The first one, of course, 25% relative reduction in risk of premature mortality from cardiovascular disease, cancer, diabetes, or chronic respiratory disease. Also, 30% reduction from prevalence of current tobacco use, 10% reduction from the harmful use of alcohol, 30% reduction the intake of salt and sodium, and here the link between salt and sodium and cardiovascular disease, as well as 10% reduction of the prevalence of insufficient physical activity. Again, 25% reduction in prevalence of raised blood pressure. So, as you can see here, all those targets should be adopted by member states, and we should all work together to achieve, which is a big challenge. Now, in what we did in EMRO, we have developed policy priorities for preventing obesity and diabetes. And prevention, when it comes to diet-related risk factors for diabetes, they are the same. So we have almost 37 evidence-based cost-effective intervention. First of all, restricting marketing of unhealthy food to children. Reformulating processed food, for example, reduce salt content or sugar content on food, and taxing sugary drinks. And this morning we had very interested presentation on this topic. Subsidizing fruits and vegetables. As you can see, not everyone have access to fruits and vegetables. If there is any way to subsidize the fruits and vegetables, that would be great. Legislation to ban the use of industrial trans fatty acid. You know, trans fatty acid is really common problem in the region and in Pakistan, because trans fat is associated with the cardiovascular disease. And we need really to work with industry to reduce or remove trans fat. And of course, this required legislation from the government. You need only legislation enforced by regulatory measures. And also, of course, improving food in public health institutions. For example, we have schools, we have universities, we have military, and all these institutions, they serve food. We have to make sure what we are serving is really healthy. So you have to revisit the menus of the hospitals, of the institutions. At least we can start from the area where we have access and we have to implement. For example, most of the hospitals, they don't have proper nutrition program considering the healthy aspects. So we have to review all the tenders, the procurement. Also implementing front of pack labeling. Look, information or advocacy is essential to the consumer. At least food label should show the content or a signals if this diet is healthy or not. Promoting of breastfeeding, as I discussed earlier. And also providing nutrition education and counseling. For example, people who lives with NCDs, they need nutrition counseling, and we should integrate it through primary health care. In most of the developed countries, they have a clinical dietitian, and he has a major role to advocate and to support the medical team. Of course, mass media campaign also is very important. In terms of the regional nutrition strategy, and which is also available online, we have identified 6 pillars to address double burden of malnutrition, overnutrition and undernutrition. The first one, ensure sustainable, resilient food system for healthy diet. Now, we talk about food system. Now, if you would like to address the prevention and nutrition, you have to look at comprehensive package. And now we have, or we are planning to have a global conference in Japan this year in September. And this conference focused on healthy diet. So most of the world leaders are going to meet and to address food systems. So we encourage, of course, Pakistan to work in this direction at different levels. Second, aligned health system, providing universal coverage for essential nutrition action. You know, the diagnosis and the prevention start during the infancy and childhood. And from primary health care, we should really conduct growth monitoring. All children should be monitored, and their weight, heights, and their growth to ensure, of course, healthy growth, as well as to ensure that if the child is obese, we can go for early intervention. Social protection and nutrition education. There is, of course, subsidy program, there is a protection program from the government, safety net. All these should focus also on healthy aspects. Trade and investment for improved nutrition. Of course, when we talk about healthy diet, there is a trade between countries. So we have to monitor our borders. And we cannot monitor our borders unless we have legislations, we have standard and specification. Safe and supportive environment for nutrition at all ages. Of course, in Pakistan, nutrition and non-communicable disease has been set up as a priority by Minister of Health, the Federal Minister of Health, and as well as by the provinces. So we need really to continue to create a supportive environment. And of course, governance and accountability is very important. The Ministers of Health approved the regional framework to scale up action on obesity prevention in Eastern Mediterranean region, which was held by the regional committee 2 years ago. And this, as you can see, obesity prevention, we have created what we call cost-effective intervention. And starting with physical measures like adding taxes on soft drinks or subsidized to promote healthy diet, ensure procurement and provision of healthy food in public institutions like schools, hospitals, military, use of food standard, legal instruments, and other approaches to improve the national or local food supply. And here I would like to highlight that the multi-sectoral approach. NCD prevention is not only the work of Ministry of Health. We need to work with the trade, industry, agriculture. All sectors are involved, and this is why we need multi-sectoral coordinated body to coordinate between all key partners. Of course, we talk about prevention, we talked about physical activity, mass media campaign, breastfeeding, food reformulation. For example, look at the food highly consumed in Pakistan, like bread. We have to monitor the salt added to bread. So we have to set up regulation, and we have to set up advocacy campaign. And again, maybe food served in restaurants. We have to advocate to the restaurants or to the people working there that they should maybe reduce the salt. You know, as you know, if we reduce 1 gram salt every day, that means it reduced the incidence of heart attack by 17%. So we have to convey these health messages to the policymakers as well as to the people engaged. And again, healthcare system is included in this framework. So it's available online, and this framework can be adapted by Pakistan. Now we talk about opportunities in health system. We have now investment in health system. And in health system, of course, we talk about universal health coverage. And as we can indicated that prevention started from primary health care, from maternal and child health care, monitoring of the child health, his growth monitoring, as well as nutrition counseling. And in this case, we need to include this program as part of the health system. We have, I know in Pakistan, you have qualified people, you have very advanced university, you have many graduates. So each and every primary health care should have one clinical dietitian or one nutritionist so that they can help and to implement the prevention measures. And also, as I mentioned, we should really work in food system, and we should look at comprehensive or holistic approach when we deal with food. And solution already exists to make healthy, sustainable food the most accessible and affordable and desirable choices, like implement comprehensive regulatory and policy framework to ensure availability of healthy food. What we need is legislation. What we need is really standard and specification to regulate the food produced by industry and imported. Also increase public health investment for healthier food product. I think we need at public level, like safety net program should encourage and promote fruits and vegetable consumption. Again, support shorter supply chain for fresh food delivery program and work with food industry. You know, working with industry is also another step. If you meet with the industry and let them go for voluntary until you have mandatory regulation to cut salt, to cut sugar, and to cut, of course, saturated fatty acid, because some of the industry, they are moving from trans fatty acid elimination to palm oil or saturated fatty acid, as if we have done nothing, because we are moving from one problem to another problem. And here, as I said, that when you develop legislation, you have to make sure that what you are producing is healthy. This is example from Oman. We developed a framework of action for Oman. And here we have linked food supply, food environment, and also consumer behavior. And as you can see here, school feeding program, and I think most of the countries, they have school feeding program, school canteen program, public institutions, all linked together with the government policies. And again, when we talk about food supply chain, we import most of our food. So if we import the food, let us make sure what we are importing is healthy. What you need is legislation. So we are really looking forward to have a framework of action on food system for Pakistan. And we are ready in WHO to support any institution or Ministry of Health or any provinces to develop such a framework. And we can work with you in this direction. Here, example of the impact of sin taxes from the region. It has been adopted by GCC countries. 6 countries adopted 50% sin taxes on soft drink and also 100% on energy drinks. As you can see, there was a sharp reduction in Saudi Arabia, and we have a new paper published also in the rest of the countries. So I think such intervention can bring changes, and we have evidence. And finally, we have already tools and guidelines to help you to go for policy statement on salt, fat, sugar reduction, on also promoting healthy diet. And we are ready in WHO to provide any support at provincial level or at national level to promote healthy diet and address NCD risk factors. Thank you very much.
Thank you, Dr. Ayub. This conference is basically aiming at devising some recommendations to the government vis-a-vis the policies for food and taxation about these things, which reminds me of a small story. Michelle Obama, President Obama's wife, take it to her heart that she will devise a plan to make sure that the school children in America will get proper diet. And after several years, she had a bill passed with much effort and everything, but it took just one signature from Trump and all those things were reversed. So sometimes the governments move in the right direction, but then the politicians have those gains reversed with just one stroke of pen. The next speaker needs no introduction. Dr. Abdul Basit is probably the lead diabetologist in our country, leading the Bakai Institute of Karachi. He has got tens, maybe hundreds of papers to his name. He's an internationally recognized figure, and he'll be talking to us about diabetes and non-communicable diseases. This is a keynote address, invited keynote address. Dr. Abdul Basit, can you hear me?
Yes, and can you hear me too?
Yes, sir, we can, sir. Please start off.
Can I have the first slide, please? Or do I share the slide myself? Shall I?
So please do share the slides.
I have to be given rights for it. I don't know how to do it. I have been sent the presentation yesterday.
Shut off your computer, please.
Hang on, I'm
here. Your slide.
Yeah, okay.
Yeah.
Okay, so we have your slides. Dr. Basit,
Right.
Please go on.
Yeah, thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. First of all, many thanks for inviting me. It's an honor and pleasure to be part of this August conference and galaxy of speakers. I can see the program is very rich, especially as regards lifestyle changes, prevention. Right now, our nutrition fellows and covered by WHO, ministry, etc. So what I did is, in fact, knowing that I am the only one who belongs to diabetes, works for diabetes, lives for diabetes care, etc. So I titled myself that I'll be giving a brief in the next 20 minutes about current status of diabetes care in Pakistan. So let us start with a very old slide, 94 to 98. The first National Diabetes Survey of Pakistan took place in collaboration with WHO, and they had shown diabetes around 11% plus and IGT 9% plus, which makes glycemic dysregulation around 20%. That was 94 to 98, and that was the first survey to ring the alarm bells that something is going to happen in Pakistan, which will be very detrimental for health as a nation. We then did a survey of metabolic syndrome, which was a term coined in those days for pre-diabetes, and we found metabolic syndrome of a figure of around 49%. So 1 in 2 persons were having pre-diabetes at that stage. We then said that this is a problem of 25-year-old plus. Let's see what's happening in 15 to 25-year-old people. So we went to villages and hub, and we went in 2002 and then in 2009. And lo and behold, we found that even in this young adolescent age, obesity, hypertension, impaired fasting glucose, smoking habits, family history of diabetes, all is either doubled or tripled. So we said, let's look into the children. And this is how we went to schools. Very difficult study to conduct in a school. This was the most difficult study of my lifetime. And I've been having 200 plus publications in which you have to take samples. Children should come fasting to school and have a sample of fasting glucose, lipid profile, and insulin, etc., which my predecessor, Kalna Shahid, has shared the study. So I won't share that study too long, but I would suggest that at this stage, we said that overweight and obesity children is increasing. And that was way back in 2005. So from there onwards, we have been trying to scream and say, look, something has to be done in Pakistan if we want to talk of diabetes care or improvement and prevention of diabetes. So this was a national survey again, done with the collaboration of Ministry and PHRC, now 5 years old. And what it shown then came in the Atlas in IDF 2019. And I happened to be part of the IDF Atlas committee comprising of 16 people globally. And we have 19.4 million people with diabetes, 2019, right? More frightening is this figure that they suggested that if nothing is being done, in 2030, we will have 26 million people. And in 2045, we will have 37 million people with diabetes. Now, what has happened? People have developed prevention programs, and what we have done. This is unofficial results of 2021, the Atlas, which is going to come in November. I again have the honor and privilege to be part of this IDF Atlas committee as well. And in Pakistan, now the numbers which is coming in November is 33 million already. We were supposed to have 26 million in 2030. We in 2021 are already having 33 million people. जिस कौम में 3 करोड़ लोग डायबिटीज के हों और उस कौम में डायबिटीज प्रिवेंशन प्रोग्राम ना हो, न्यूट्रिशन के नेटवर्क्स ना हो, civil society, politicians, multiple stakeholders, they are struggling to find their role, and they are saying, अच्छा भाई diabetes बढ़ रही है, चलो दवाइयाँ ले लेंगे, ये वो etc. So tremendous efforts are needed at all levels, and I congratulate the organizers for selecting this topic. I won't go to the details of hypertension, obesity, dyslipidemia, tobacco, all published papers of the same survey and have been covered by many speakers and will be covered till tomorrow as well. Talk about the macrovascular disease burden. We are having more than 8 crore, 10 million people plus having heart disease, 27 lakh लोगों को stroke, 33 lakh लोगों को peripheral vascular disease. So the numbers are enormous. Same for microvascular disease. So we decided that we shall have prioritization strategies. We as clinicians, we as BIDE, we as Diabetic Association, we decided that we shall have prioritization strategies. And with these strategies also go way back 15, 20 years ago. Our priorities were diabetes education. Awareness कैसे create करेंगे? And unless we educate our people with diabetes, then comes payers with diabetes, then comes the carer with diabetes, then comes community for diabetes awareness. So we need a national wide program. We had diabetic foot as our priority क्योंकि हमारे यहाँ 4 से 10 लाख लोग हर साल टांग लूज कर जाते हैं because of diabetes. We talk of polio कि एक बच्चा पोलियो का आ गया, polio was preventable. Believe you me, 90% of diabetic foot is also preventable. And we talk of diabetes and children. So diabetes education में हमने diabetes educators course कराने शुरू किए, nurses को train करना शुरू किया, इंटरनेशनल लेवल की डायबिटीज एजुकेशन कॉन्फ्रेंसेस शुरू करी, पब्लिक अवेयरनेस प्रोग्राम शुरू किए. We were recognized for our services internationally. So BIDE is IDF Center of Education, IDF Center of Excellence. Coming to foot, we train podiatrists at a very low cost. 150 पोडाइट्रिस्ट से आप कह लें पट्टी वाले 6 हफ्ते के ट्रेन किए पूरे पाकिस्तान में. दिस इज लो कॉस्ट पोडाइट्री कंपेयर टू 8,000 पाउंड का कोर्स होता है इंटरनेशनली पोडाइट्री का. We established 150 diabetic foot clinics and reduced the amputation rate by half. So confirming what I said earlier that amputations are preventable. And I again would say that हमारी international bodies ने diabetic foot services को recognize किया. These are consensus group meetings. ये 70-80 लोग पूरी दुनिया से बैठते हैं. They sit every 4 years to develop consensus guidelines of diabetic foot. And I happen to be part of all 4 from 2007 onwards. तो पूरी दुनिया में diabetic foot की management कैसी करनी चाहिए, we are part of those guidelines. And what we have lately developed is भाई चलो आप अल्सर बचाएं, prevent ulcer instead of amputation. So we have started giving footwears, customized footwear देते हैं. ये 2-2.5 हजार रुपए के जूते बन जाते हैं. But look, if you see, लो रिस्क में कोई अल्सर नहीं हुआ अब तक, मॉडरेट रिस्क में नहीं हुआ, हाई रिस्क ग्रुप में नहीं हुआ, वेरी हाई रिस्क ग्रुप में जिसमें वर्ल्ड वाइड रिकरेंस रेट 50% है, हमारा 26% है. एंड इस पूरे साल में इन फुटवेयर वालों में किसी में एम्पुटेशन नहीं हुई. इंसुलिन एक्सेसिबिलिटी की बात की लोगों ने, ड्रग्स की बात की कि पहुंच जाए, सबसे बड़ा मसला इंसुलिन का. वी स्टार्टेड दिस प्रोग्राम 2010 to 2013 with funding from World Diabetes Foundation. 34 centers बनाए in the province of Sindh जहां हम बच्चों को फ्री इंसुलिन दे रहे हैं. और ये इंटरनेशनल अगेन got a recognition from Life a Child program of IDF that we are giving free insulins to 1900 plus बच्चे, children who will lose life otherwise. Alhamdulillah, now in KPK, there are insulin banks in 23 districts which give free insulin. Madam Salwa Tanveer is doing a pioneering work in Multan giving free insulin. We have started in Balochistan very lately. Loralai, Barkhan, Mekhtar, Quetta, we are giving free insulin to non-affording type 1 diabetics. Next comes capacity building. आप दवाइयाँ वगैरह भी फ्री दे सकते हैं, पर आपको कैपेसिटी बिल्डिंग करनी है, डॉक्टर्स को ट्रेन करना है फॉर डायबिटीज. वी हैव स्टार्टेड द डिप्लोमा इन डायबिटीज कंप्लीटिंग 19 बैचेस नाउ. 400 plus doctors trained across the country to look into diabetes care, especially at primary care level. For secondary care, Pakistan Endocrine Society came forward in 2001 and we have started fellowship, post-fellowship in diabetes and endocrine to train personnel for secondary and tertiary care. मैनेजमेंट अपडेट्स पे थोड़ी सी बात कर लेते हैं. प्रोफेसर समर शेरा, लेट अल्लाह उनकी मग़फ़िरत फरमाए, ही डेवलप्ड द फर्स्ट नेशनल क्लिनिकल प्रैक्टिस गाइडलाइंस 1999. I had the honor and pleasure at that time also to develop this important document, but this document needed revision. So in 2016 we developed a document called PROM document. ये अब हम गवर्नमेंट्स के पास लेके जा रहे हैं, मिनिस्ट्रीज के पास लेके जा रहे हैं. In fact, this document has been endorsed for the whole MENA region, Middle East, North Africa. इस document के जरिए हम कह रहे हैं कि these are the ways to manage diabetes. Special इसका component है referral policies from primary to secondary to tertiary care and vice versa. आप खुद सोच सकते हैं 3 करोड़ लोगों के साथ no richest even country in the world can cope with this burden on a secondary or a tertiary care level. So importance is primary care level. And as I said, that these guidelines were presented to MENA Council in Khartoum and in Alexandria they were finalized. फाइनल थिंग है, डायबिटीज में और कितने एस्पेक्ट्स हैं जो बच गए हैं, अभी तक काम नहीं हुआ या काम करना है. वन ऑफ देम फॉर एग्जांपल इज डायबिटीज एंड रमदान. करोड़ों लोगों की रोजों की बात हो रही है, अब करोड़ों लोगों की, और वर्ल्ड वाइड आप सोचें millions of them. So we started this concept of diabetes and Ramadan alliance with collaboration of IDF way back in 2013. Now this dark group has matured a lot. We in Pakistan are having Pakistan Ramadan study group headed by Professor Yaqub Saab. This is IDF President Namchu honoring us in his present 2018. हर साल कॉन्फ्रेंस करते हैं. Gestational diabetes, कितने अफसोस की बात है कि एक विंडो हम मिस करते हैं कि 20, 25, 30 ईयर ओल्ड प्रेग्नेंट वेमेन आती हैं उनको उस वक्त शुगर निकलती है, गायनी वाले कहते हैं जी आपको बेबी शुगर है, बेबी डिलीवर हो जाएगी, शुगर खत्म हो जाएगी, और इनफैक्ट ये तो होता है. 90% of them, they deliver the babies, the sugar goes down or completely vanishes, just to come back again after 2-3 years as proper full blown diabetes. ये इतना अच्छा विंडो है कि इसके अंदर हम अगर मरीज को काउंसिल करके लाइफ स्टाइल मॉडिफिकेशन पे डाल दें तो उसको 20-30 साल तक we can prevent from diabetes, but we are losing this window as well. So we developed a GDM advocacy board, GDM manual, GDM registry, etc. फाइनल पॉइंट ये है कि उस मुल्क में आप अगर मेजर लेवल का काम करना चाहते हैं, यू नीड टू हैव अ डिजीज रजिस्ट्री. सो वी आर डेवलपिंग दिस डायबिटीज रजिस्ट्री ऑफ पाकिस्तान इन कोलैबोरेशन विद हेल्थ रिसर्च एडवाइजरी बोर्ड. हेल्थ रिसर्च एडवाइजरी बोर्ड इज अ रजिस्टर्ड बॉडी working in collaboration with PHRC, Ministry, DREP, etc. And I have the honor and pleasure to be vice chairman of it, with Ghaffar Billu Saab being the chairman. हम लोग 8 साल से पूरे पाकिस्तान में वेरियस रजिस्ट्रीज डेवलप करा रहे. अभी डायबिटीज रजिस्ट्री इन्फेंसी फेज में से 55,000 लोग रजिस्टर्ड हुए, बट वी आर नाउ एम्बार्किंग ऑन अ क्लाउड टेक्नोलॉजी, एंड इंशाल्लाह विद इन 2 to 3 years we will be having data from some 2,000 centers into the registry. This was the first annual report of the registry we got published. फाइनल बात मैं करना चाहूंगा, जैसे लोग बात कर रहे हैं, और ये पूरी कॉन्फ्रेंस आई थिंक इज डेडिकेटेड टू प्राइमरी प्रिवेंशन, मेन एम होना चाहिए. तो पाकिस्तान में प्राइमरी प्रिवेंशन ऑफ डायबिटीज काम भी करेगी अगर हम डायबिटिक से पहले स्टेज IFG IGT में रिकॉग्नाइज करेंगे लोगों को एंड इंटरवीन करेंगे, तो वो डायबिटीज से बच भी सकते हैं कि नहीं. इज देयर अ डॉक्यूमेंट्री एविडेंस? एंड आंसर इज यस. वी डिड अ longitudinal study, prospective study, intervene with lifestyle modifications, with lifestyle plus metformin modifications, and we had one of the highest numbers of risk reduction globally. 71% लोग बच जाएंगे डायबिटीज से, IGT अगर हो गई है, अगर आप उनको लाइफ स्टाइल पे डाल दें, और 76% अगर आप लाइफ स्टाइल प्लस मेटफॉर्मिन पे डाल दें. सब क्या काम रह गया? इसका मतलब है नेशन वाइड कैंपेन रह गई आपको लोगों को डायबिटीज से बचाने के लिए. अब लेकिन ये कैसे पता चलेगा कि कौन IGT और कौन IFG है? तो अगर आप करोड़ों लोगों का GTD करने जाएंगे तो ये तो वैसे ही खरबों रुपए की बात. तो वी डेवलप्ड अ रैपिड स्कोर, रिस्क असेसमेंट ऑफ पाकिस्तानी इंडिविजुअल्स फॉर डायबिटीज. जैसे फिनलैंड वालों ने फाइन रिस्क स्कोर बनाया, ऑस्ट्रेलियंस ने ऑस्ट्रिस, जर्मन स्कोर है, कैनेडियन स्कोर है, इंग्लिश स्कोर है, इंडियन स्कोर है, थाई स्कोर है, ये पाकिस्तानी स्कोर. 3 सवाल. अभी जितने लोग ऑडियंस में बैठे हुए ये अपने आप को देख सकते हैं कि एम आई आर डायबिटिक और नॉट विदाउट लुकिंग इनटू ब्लड ग्लूकोज. अगर आपकी एज 40 से कम है तो आप 0 लगा लें, 40 to 51, 50 + 3. एक सवाल ये हो गया. आप लोग खुद अपने अपने स्कोर्स कैलकुलेट कर सकते हैं. अगर मेल्स की वेस्ट सरकमफ्रेंस 35.5 इंच से कम है 0, ज्यादा है 2 लगा ले. दूसरा सवाल हो गया. तीसरा सवाल, फैमिली हिस्ट्री नहीं है डायबिटीज की 0. अगर एक भी अम्मी अब्बू बहन भाई बच्चों में से एक को भी डायबिटीज है 1 लगा ले. अगर ये स्कोर 4 आ रहा है, सॉरी विमेन में अगर वेस्ट सरकमफ्रेंस 31.5 इंच से कम है 0, इससे ज्यादा है 2 लगा ले. इफ योर स्कोर इज 4 और मोर, you are at a risk of developing diabetes. Contact your doctor and get yourself checked. अब हम कह रहे हैं ये कितना आसान स्क्रीनिंग स्कोर है. पाकिस्तान में 10 करोड़ से ज्यादा लोग मोबाइल इस्तेमाल कर रहे हैं, 30 सेकंड लग रहे हैं. आप मोबाइल से मैसेजेस भेज दीजिए, लोगों को पता चल जाए कि am I at a risk of developing diabetes or not. We requested PTA through Iram Ghafoor, one of our diabetes educator who had links with people in telecommunication. टेलीनॉर ने अब तक हमारी बात मानी, एक दफा 1 करोड़ मैसेजेस भेज दी. मगर ये मैसेजेस बार बार जाने चाहिए. जब से ये कोरोना हुआ है, ये आंसरिंग मशीन्स पे जवाब आता है, आप वैक्सीनेट कराएं, सैनिटाइज करें, एक्सेट्रा एक्सेट्रा. हम ये कह रहे हैं अल्लाह करे ये एपिडेमिक खत्म हो जाए. देयर मस्ट बी अ टाइम व्हेन पीपल शैल बी टॉकिंग अबाउट डायबिटीज रिस्क स्कोर एंड रिस्क प्रिवेंशन. बिल्कुल फाइनल पार्ट, मेरी 2 स्लाइडें रह गई. इतना सारा काम डायबिटीज का फिर भी पाकिस्तान में हो गया है. मे बी इन साइलोज, मे बी हम नहीं जानते, मे बी बहुत थोड़े लेवल पे, मगर हो गया। ये दो बड़े क्वेश्चन मार्क्स अभी भी बाकी। दीज टू बिग क्वेश्चन मार्क्स नीड टू बी एड्रेस। एक के लिए आपको एडवोकेसी चाहिए, लाइक इरम गफूर लीडिंग डायबिटीज चैंपियंस, डॉक्टर सना अजमल लीडिंग मीठी जिंदगी, सिविल सोसाइटी जैसे आप लोग माशाल्लाह काम कर रहे हैं। मैं आई एम ऑलवेज एनवियस ऑफ द वर्क पनाह एंड अदर ऑर्गेनाइजेशंस आर डूइंग। मैं तो आई फील बिलिटल्ड टॉकिंग इन फ्रंट ऑफ यू कि हम लोग तो कुछ भी काम नहीं कर पा रहे, सिर्फ मरीजों को दवाइयाँ दे देते हैं, सुबह से शाम तक क्लिनिक करते हैं। आप लोगों को देख के आई एम वेरी इम्प्रेस, बट वी नीड एडवोकेसी ग्रुप्स। लाइकवाइज ये एच आमिर का ग्रुप है पिशावर केपीके में, इन्होंने ये डिटॉक प्रोग्राम इनिशिएट किया, पूरे केपीके में ये बोर्ड लगवा दिया। अगेन प्लीज नोट देयर स्कोर कि अगर आपको ये है तो प्लीज कॉन्टेक्ट द डॉक्टर। न्यूट्रिशन की बात हुई, सो आई जस्ट वांट टू टच 2 स्लाइड ऑफ न्यूट्रिशन। Mike Lean, Professor Mike Lean came from Glasgow, Scotland to Pakistan and talked about a healthier pizza, a pizza that is healthier than a salad. अगर यहाँ कुछ बच्चे ऑडियंस में बैठे हैं या कुछ मुझे सुन रहे होंगे यंगस्टर्स, तो वो कहेंगे भाई वाह मजे आ गए, नाउ पिज्जा एवरी डे। यस, बिकॉज पिज्जा इज हेल्थियर देन अ सैलड एंड कंटेन्स ऑल 47 न्यूट्रिएंट्स। ये स्कॉटिश पिज्जा के नाम से मशहूर है, स्कॉटिश टीम ने डेवलप किया है। आप वेबसाइट पे जाएं और देखें कि स्कॉटिश पिज्जा कितना चल रहा है और कितना मजेदार है। हमें वी नीड टू इन्वॉल्व फूड इंडस्ट्री, जैसे अभी मेरे प्रेडिसेसर अयूब साहब ने कहा, वी नीड टू इन्वॉल्व फूड इंडस्ट्री। व्हाई कांट वी हैव हेल्दी बिरयानी? कर्नल शाहिद साहब हमारी बिरयानी को बहुत बुरा भला कह रहे थे, हम दिल्ली वालों को ये बहुत बुरा लगता है कि हमारी बिरयानी को कोई कुछ कहे, मगर चले, व्हाई नॉट हैव अ हेल्दी बिरयानी और अ हेल्दी कढ़ाई और अ हेल्दी कोरमा, एंड दीज आर ऑल पॉसिबल। So one is role of multiple stakeholders. ये खाना हमें भरना है, and this conference and conferences like this is trying to help bridging the gap between the personnel. एक खाना अभी भी रह गया, and that is 1995 में ये नेशनल एक्शन प्लान बना था। हिलरी किंग लेट, he also passed away unfortunately. Prof. Shera passed away. Dr. Sanya is mashallah very much still here. And I hope that she and others are able to play active role again into NCDs and diabetes prevention. We had this Pakistan Diabetes Leadership Forum supported by WHO and IDF and WDF, and the ministry took the initiative. But then what's happening at ministry level? ये अभी sin tax की बात आई. We pushed for sin tax. PANAH supported us, and we were so keen that this time it will happen. We wrote to Chairman FBR. I got the letters from IDF MENA region, from Pakistan Cardiac Society, from Pakistan Hypertension League. So many letters, the whole plethora of doctors and civil society pressing for taxation on SSBs. And what happened? Nothing happened. And you know why didn't nothing happen? Because one beverage company came along and gave that much of revenue to the government for green life or healthy water etc. कि उन्होंने कहा जी ये टैक्स वैक्स हम नहीं लगा रहे, सिन टैक्स। सो लेट्स जॉइन हैंड्स टुगेदर टू गेट द एडवोकेसी प्रॉपरली डन। अब ये लास्ट टाइम जब सेंसस हो रहा था, आई रिक्वेस्टेड टू FBR टू द मिनिस्ट्री, डॉक्टर समरा वाज सो काइंड टू राइट अ लेटर स्ट्रेट अवे, भाई ये 5 डिजीजेस रजिस्ट्री के अंदर ले लो भाई, सेंसस के अंदर, गोइंग डोर टू डोर। Unfortunately, at that stage, we were told that हम लेट हो गए और 25 million papers print हो गए सेंसस के, नेक्स्ट टाइम देखेंगे इंशाल्लाह। So I finally would like to say that yes, we need role of multiple stakeholders. We in Sindh had 2 recent success stories by joining hands with PPHI, doing an MOU with them for primary prevention, diabetes registry and awareness, and only very lately with the Sindh government itself. Dr. Azhar Niaz is here, Kazim Jatoi Saab is here. We had an agreement signed that inshallah जितने सिंध के अंदर प्राइमरी रूरल हेल्थ और बेसिक हेल्थ यूनिट्स हैं, सब के अंदर डायबिटीज प्रिवेंशन और अवेयरनेस की बात की जाएगी इंशाल्लाह। So the final question mark was governance. We need good governance to take care of diabetes and NCDs. Here I'd like to thank all the associations and collaborations which I enjoy nationally, and the whole international associations and collaborations I enjoy, and I thank you all for your attention. Thank you very much.
That was Dr. Abdul Basit, a very humble soul as usual. Our next speaker will be talking to us about school food programs, and she is Elizabeth Orlon from USA.
Hello, thank you
Orlon,
for
can you hear
having me.
Can you share your slides with us, please?
Yes. Just 1 second.
We can see you, but not your slides yet.
Yes, I'm working on it. Thank you.
We have them.
Okay, how is that?
That's good. Go on.
Okay, great. Thank you for having me. My name is Elizabeth Orlin, and I'm going to talk about the importance of regulating marketing of ultra-processed foods and school food policies. So I work at the Global Health Advocacy Incubator, where I'm the Associate Director of Research. And our role at the Global Health Advocacy Incubator is to support civil society organizations like PANAH, who are working to advance healthy food policies. So we work in several countries throughout the world, and we work on several policy areas, including enacting taxes on sugar-sweetened beverages, implementing mandatory front of package warning labels to help consumers identify unhealthy foods, removing unhealthy products from the public sector, and restricting marketing of these products. So first, I'll talk about marketing. So there's lots of food marketing everywhere. You can see some examples from Pakistan, some examples from globally, which includes everything from billboards to placement of products at the point of sale, to television advertisements, to the design of packaging, and even corporate social responsibility like donations and other acts of charity. So there are a lot of types of different advertising. So at the tip of the iceberg, you have direct advertising. So this is what you would think of when you're typically thinking of advertising. But there's also other more hidden types of advertising, like product placement, charitable sponsorships, and that includes like public-private partnerships, as well as government lobbying. So as advocates, you can look and see what types of advertising are going on in Pakistan, and also look into this government lobbying, like what the last speaker was referring to in terms of blocking potentially the SSB tax proposal. So as I mentioned, there's a lot of different marketing techniques, and this is a little bit more of an exhaustive list of things that we've seen in our global work. So that includes celebrity endorsements, even in school marketing, use of child actors, and a whole bunch of other types of marketing. So child-directed marketing is a particular type of marketing that we've seen that includes everything from brands that were created with cartoons on their packaging to partnerships between new releases of movies and the food industry. So here are some popular movies that were released in the last few years, including Despicable Me and Frozen, really popular among kids that are being featured in stores on products. So why do we need marketing restrictions? As many of the previous speakers have mentioned, over 200 million children are overweight and obese, and this prevalence is expected to continue. Children see packaging with those frozen characters or with, cartoons, and they want it. They are very excited by the fact that their favorite cartoon is on their cereal. So we need to make sure as adults, as public health professionals, that we're doing the best that we can to ensure that children don't want to eat those sugary cereals or sugary products. They are more interested in eating the vegetables or the fruits or, foods with a lot of good nutrients in it. So the industry knows that they could take advantage of this, of children by marketing. And a recent review had found in 22 studies that all of the products that are advertised to children are unhealthy products. So this is an exhaustive review. It showed that cartoon characters were used to make unhealthy foods look more appetizing to children. And it also showed that cartoons were also a more persuasive form of marketing to children. So this is really problematic, and it's one of the examples of why marketing needs to be regulated, particularly this child-directed marketing. So why does the food industry decide to target children? Children are really vulnerable to food marketing. They don't really know about nutrition. They really want that immediate gratification of having their sugary or salty snack. Children also influence purchase behaviors. If any of you have children and you take them to go shopping, you might notice that they want certain products that feature their favorite cartoon on them or want the products that their friends like to eat. And these early marketing also contributes to their lifelong habits. So their favorite snack right now might be their favorite snack later and something that they'll continue to want to buy and eat. So one place where there's been a lot of success in regulating marketing is in Chile. So Chile in 2016 enacted the Food and Advertising Labeling Law. And with that labeling law, products that don't meet specific nutrition criteria, so the unhealthy products with a lot of sodium and sugar and saturated fat, can no longer be marketed to kids. And evaluations by Dr. Popkin, who made the keynote address earlier today, and several other researchers, both locally and globally, have found that these advertising restrictions have led to fewer exposures of these child-directed marketing. So it reduced almost by half of preschooler and adolescents' TV exposure to junk food advertising, which is huge. And this is only just within the last few years that this has been able to happen. And then most recently in the United Kingdom, they've passed a very comprehensive marketing policy as well, which allows for restrictions on online and TV advertising. So this is, again, another way of protecting kids and particularly getting to this online component of advertising, which is very pervasive and something that the industry has been using for a while. And this is expected to save over $1 billion in healthcare costs for the United Kingdom, for future healthcare costs because of this regulation. So now we're going to talk about school food policies. So school food policies include the procurement aspect. So one of the colleagues earlier today was talking about the WHO's procurement policies and helping to ensure that schools purchase minimally processed foods, so not as much like the sweetened yogurts and things like that, And then also to regulate the school environment to make sure that there's not a lot of advertising and promotion at the school where kids spend a lot of their days. So the evidence on school food policies is very strong. It shows in over 90 studies that having good school food policies can increase children's good nutrition habits, even outside of the school environment. So even if you make this one change to this one meal that children are having, as well as to change the school environment and make sure that it's not having a lot of advertising, that can make a huge difference in diets. So there's a case study from Brazil. Brazil has a program called PANAH, and it is a best practice program for school foods. So the advocates that we work with in Brazil have really built a coalition to ensure that different states are able to implement good school food policies. And so this PANAH regulation sets restrictions to ultra-processed foods. It allows states to ban sale and advertising of unhealthy food products. And it also helps local farmers. So local farmers are now providing the foods to the schools. And there's a recent study that just came out that showed that students who are eating these school foods every day, so 5 days a week, they are actually experiencing lower rates of obesity and overweight than students who aren't eating school foods. So this is a really huge breakthrough. So there are many food policy opportunities in Pakistan right now. So as multiple speakers have mentioned, the rate of overweight and obesity is really increasing here. And one speaker mentioned Mexico and how Mexico had the highest rate of obesity. So now Mexico has implemented many food policies, and Pakistan should do the same in order to curb those rates of obesity and overweight. So what can be done in school environments? So Pakistan has imposed restrictions on availability of sugar-sweetened beverages and energy drinks at schools through provinces. One of my colleagues at PANAH mentioned that the Punjab Food Authority introduced traffic lights for the different categories of foods. However, flavored milks and yogurts are still highlighted as a main choice in the school canteen menu. And that's problematic because these are attractive products. They're sweet. They generally have high levels of sugar. So any sort of foods that are promoted in the school environment shouldn't have that level of sugar and could include unflavored milk and unflavored, unsweetened yogurt. So regulating the marketing and availability of foods and drinks with high levels of process should be limited within the school premises as well as the surrounding areas. So any sort of shops that are right outside of schools should not be able to sell sugary drinks and not be able to market sugary drinks as heavily as they do. So ultimately, regulating marketing is a really great first step of making sure that kids are protected from this harmful exposure that is really a lifelong exposure. As many of the other speakers have mentioned, implementing passing an SSB tax or sugar sweetened beverage tax would be really, really beneficial, not only to kids, but also to adults in reducing the rate of consumption and also reducing non-communicable diseases in the future. And a study done by PANAH and some colleagues had found that 85% of Pakistanis support having these taxes and using them to fund public health and nutrition programs. Another policy that can be implemented is mandatory evidence-based front of package labeling. So I have one example here where you could place this on a product and it says high in saturated fats. You could have one that says high in sodium, high in calories. You could have these in local languages to make sure that people know that these products are harmful and that they can choose other products of the same type that don't have these types of labels on it. And as previously mentioned, a package of policies like in Chile, which has a tax front of package labeling policy, school food and marketing restrictions would be a really great first step in reducing the rate of NCDs and obesity in Pakistan. So thank you very much for your time. I am available during this session. If you have any questions, you can use the Q&A box. And I am also happy to address any questions via email. Thank you very much for having me, and thank you to the conference organizers.
Thank you, Dr. Orlan. And this brings us to the last lecture, and this will be about the distribution of non-communicable diseases. And we have here Dr. Shahid Beg of Pakistan Science Foundation to talk to us about this. Dr. Shahid Beg, please.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and a very good afternoon, ladies and gentlemen. Thank you for inviting me. This is really a great honor and pleasure for me to be among the galaxy of clinicians, scientists, and students. And my compliments and congratulations to the organizers of this wonderful forum which you have organized today. Professor General Kiani, Professor Wajid, Professor Gurman, my senior colleagues. It's really an honor. Very well done. You have touched today a very important topic of non-communicable diseases. Mostly the speakers talk about diabetes, cardiovascular diseases, and cancer, etc., obesity. But let me share with you, since I am a geneticist by profession, and I have been working on the genetic diseases, there are more than 7,000 genetic disorders, which include metabolic disorders also. And only half of these have been characterized so far at the molecular level. And for the precise prevention, early diagnosis, and precise treatment, the molecular characterization is essential. These diseases are known as rare diseases, but let me tell you, in Pakistan, these diseases are not rare. If we talk about blood disorders, intellectual disability, skin disorders, eye disorders, and profound bilateral hearing impairment, we have the highest number of affected children in Pakistan as compared to any population. There are several reasons. It can be our population growth rate, environmental factors, but in the inherited diseases, the births of affected children is mainly because of cousin marriages in Pakistan. More than 60% of the marriages in Pakistan are cousin marriages. And by the cousin marriages, the risk of complex disorders and monogenic disorders increased many times. We have the highest number of people with intellectual disability, highest number of thalassemic children which are transfusion dependent. And you name the disease. In other part of the world, these are rare diseases. In Pakistan, I tell you, I'm working on these diseases from the last 37 years. We have the highest number of affected children in Pakistan. If we talk about thalassemia, more than 6% of our population is carrier of thalassemia. It means we have more than 11 million carriers of thalassemia in Pakistan. Same is the case with the hearing impairment, eye disorders, and intellectual disability. Similarly, the incidence of complex disorders, as Dr. said, these diabetes or obesity, it is caused if you don't run, but it runs in your family. It's true. These are complex disorders, but these are genetic disorders. There are multiple genes. How these can be prevented? These can be prevented by working on their genetic basis to find their genes and the genetic variants, which can provide early diagnosis and targets for the precise treatment. You know, now there are several examples of gene editing where some genetic diseases, some metabolic diseases have been cured. Some examples include hemophilia and thalassemia, and there are many metabolic disorders which are not being diagnosed because there is a battery of tests available for these metabolic diseases, but we are screening only maybe 30 or maybe 50 or 100, but there are 100 of metabolic disorders, and some of these are curable if these are diagnosed at an early stage of the life. So what Pakistan Science Foundation, let me come to this Science Foundation and why I'm here today. The role of Science Foundation. The role of Pakistan Science Foundation is to fund the scientific activities in Pakistan for the quality life and economic impact in the country, to promote the science and research in Pakistan and popularize the science in Pakistan. We have a very big mandate, but unfortunately, you know, the science in Pakistan is not of very high quality. We have, alhamdulillah, we have excellent clinicians, wonderful surgeons and scientists, but what we lack is the science culture and support to the science. You know, science is a very expensive business, especially this science and research in the medical science is very expensive. It needs a lot of money. It needs team. We are excellent scientists, but we are working in silos. Some people are working in an isolated laboratory in Karachi, in Islamabad, in Faisalabad, in Lahore, in Peshawar. But how the science is working in the world, it is always a collaborative science. It's a teamwork. In a team of scientists, in a research group, there are clinicians, there are biochemists, there are geneticists, bioinformaticians, statisticians, people from public health, people from bureaucracy, people from government. And this is what we have to establish here. Pakistan Science Foundation was established more than 40 years ago, or rather 47 years ago. Its mandate, it's very heavy mandate. It was established on the template of National Science Foundation of USA. But if you look at the budget of National Science Foundation of USA and Pakistan, there is no comparison. Till last year, the budget of Pakistan Science Foundation was very meager. They used to fund, but the funding was not sufficient to undertake a scientific question or to do a project on any problem with some meaningful results. I took the charge 6 months ago, and alhamdulillah, in the last 6 months, we have increased the funding for research 5 times. And we have introduced several schemes. Science funding is one of them. Then science popularization. For example, you have organized a wonderful event today, and we very much appreciate and believe me, now Pakistan Science Foundation is your partner, and I'm part of your team. In addition to funding for the research and science, we provide funding for the organization of such events. Please organize as many events as possible. You can organize maybe 4 events a year or more than that, and we will try to provide the maximum funding, whatever is possible in our resources. And invite international speakers, guests. We can provide their traveling, lodging, your printing material, your food, etc. So this is one of the mandate of Pakistan Science Foundation, to promote the scientific activities and to popularize the science. Prevention of diseases is very important. You see, the non-communicable diseases, you know, some of these are curable, but some of these are not curable. But the prevention is possible. By just counseling, you can prevent some of the diseases. But as I said, these are mostly genetic diseases, and just by counseling, you cannot prevent these. You need to establish genetic diagnosis, genetic profiling, premarital screening, prenatal diagnosis, non-invasive prenatal diagnosis, inborn screening, and very sophisticated research is required. And what we need to do, and how we have been working in Pakistan, we have been working in collaborations. You cannot be expert of everything. As I said, you need clinician with the relevant experience. You need genetic counselor, biochemist, geneticist, bioinformatician, statistician, cell biologist, and epidemiologist. So these are in different locations in Pakistan or abroad. I personally have very good experience of these international networking. I have been working in collaborations. My friends and colleagues, they have been working in collaboration. We have already established such teams. Now, Pakistan Science Foundation is preparing a database of all the research facilities and expertise which are available in Pakistan. Subsidiary organization, PASTIC, which is located in Quaid-e-Azam University. It is making a database for the research equipment, sophisticated equipment, for example, where the next generation sequencing is available, where the HPLC is available, where the high-tech microscope, imaging facility, and biochemical facility and genomic facilities are available. I'm talking in terms of medical sciences. So you can get this information from Pakistan Science Foundation, and Pakistan Science Foundation will be happy to provide you a platform to connect you with all the other stakeholders and partners which are working in silos. So I assure you once again the full support from Pakistan Science Foundation. We can make a team, and I have not seen the recommendation, but Professor Wajid has just informed me that they have made a recommendation. Please, as I said, consider me as part of your team. I'll be happy to be part of this team. So we can make a team of clinician, policymakers, some people from the Ministry of Science and Technology, some people from the Ministry of Planning, from Ministry of Finance, etc., and Ministry of Health also, and Ministry of Education. We have already made some think tanks at Ministry of Science and Technology, and I think this type of a team or a consortium is not over there. So we can discuss with you, and whatever recommendations, please, you can count on me. I'll be very happy, and Pakistan Science Foundation will be very happy to support in any way. And let me share with you this the science support which we are providing to the medical colleges, universities, and research institutions. We have several programs of research support. One of our program, which is known as Research Support Program, it is open throughout the year. if you have a research project, first I will ask you to make a team, and we have a project formulation team at the Pakistan Science Foundation. It can come to your university or your medical college, and they can provide you the guidelines how to prepare a good research proposal. You can submit this research proposal at any time of the year. Previously, the funding limit was 8 million rupees, 80 lakh rupees. Now we have increased it to 20 million rupees. So if you are a good team, your objectives are doable, you have a good research program, your track record, or your team is able to achieve the targets, then you please submit your application, download the template of the research proposal, apply to us, and it will go to the reviewers. We have 3 or 4 tiers of review. First is the screening committee, then we send it to independent reviewers, and then if the reviewers recommend it, then we hold the technical committee meeting, and if the technical committee approves it, then we fund it. So it takes around 6 months to 1 year. So if you have any good ideas, any good research idea about diagnosis, early diagnosis, establishment of any procedure or any process or any treatment, please feel free to contact us. Our team will be happy to talk to you and guide you about how to win the grant from Pakistan Science Foundation. And regarding these scientific and these events organized by PANAH, as I said, please feel free to organize as many programs as possible, and Pakistan Science Foundation will be very happy to support such activities. This is part of our mandate. We have to do it. And if you have any questions, any queries, any things to share with us, please feel free. Dr. Saab has my phone number or email contact. Please feel free and just invite me. I belong to Rawalpindi. I was raised in Rawalpindi. I have a very special love for the city. So I'll be very happy, and the Science Foundation will be very happy. Once again, I congratulate the whole team, the organizer, and you, sir, you are doing wonderful work. I think this is the best jihad against the diseases, and my best wishes and my prayers for the whole team. Thank you very much.
Before we go on to the shield distribution ceremony, I would request Dr. Waju to come up and sum the day's proceedings.
Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman, Lieutenant General Azhar Rashid, Principal at Islamic International Medical College, President PANAH, Major General Masood Rahman Kiani, Chairman, Pakistan Science Foundation, Dr. Shahid Beg. I'm taking this opportunity as the Chairman of the Scientific Committee to sum up the day's proceedings. The purpose of this summation is that I know this thing that the members from Pakistan Ministry of Science, Ministry of Health regulations are attending this conference online, as are the members from the Planning Commission at the moment, Dr. Shabnam and Dr. Samra from Ministry. The Vice Chancellor from the University of Health Sciences is also online. And we have, fortunately, the Chairman of the Pakistan Science Foundation available here, who has just spoken to us. This summation is primarily to address these 4 institutions and organizations, the instruments of the government of Pakistan.
PANAH has organized this event to highlight the NCDs from the perspective of the healthcare professionals who are actually in the delivery process of healthcare. We want to bridge this gap between the policy makers and the peoples who actually execute the policy. So the purpose was that today we should be able to make them interact with the policy makers so that the future policies that would be devised for the short term, which is a decade, the intermediate term, which is about 25 years, 2.5 decades, and the long term thereafter. Nations who are educated, who are aware of their problems and are actually looking forward to taking care of them, plan like that. And these planners, who are very, very talented people amongst us, who have been chosen to plan and make policies for us, need the help from the people who actually execute those policies. And that's the purpose of this summation. Sir, today we have had 2 sessions. The first session was primarily focused on the cardiovascular diseases, its burden in the nation, and the problems that are there and where we are going. The bottom line is that the cardiovascular disease has been overlapped with the other NCDs, particularly the metabesity and the diabetes and the obesity itself. The bad dietary habits, the poor physical activity, rather inactivity of the nation, as the President PANAH said that we are a lazy nation, has actually resulted not in the accumulation of the burden now, but this cumulative burden is multiplying every day. So the future policies need to direct. The bottom line that we have found out today is not on the primary prevention. The bottom line is we need to go for primordial prevention before the birth of the risk factor. Sir, in the first session, we looked at the biggest menace of the cardiovascular disease, which primarily is not cardiovascular, it is cerebrovascular, renovascular, peripheral vascular. And they are really big mammoth problems to surmount. In this session, you've actually addressed the problem of obesity, metabesity, the problems both at the medical clinical level and the policy making level. We have found out by this discourse that there is a cultural change which has resulted in this menace. The culture which is in slang called as the burger culture, the processed food culture, the inactivity culture, the prosperous culture. This prosperous culture has produced couch potatoes. The apple dyslipidemia physiognomy. We are a sick nation. We have not been able to touch very important subjects of mental health and mental well-being in this particular session. We'll be doing that sometimes later. We have not been able to talk about the cancers because, mind you, we are the world leaders in young women breast cancer nowadays. The menace of leukemias and lymphomas in our young population is reaching next to the top level. We need to go and address those as well. Dr. Shahid Beg just enlightened us about the uncharted domain of the genetic disorders which have never been focused on. So there's a lot to be done. So the bottom line today is PANAH endeavored today that the divide of the delivery people must be bridged today with the people who make the policies for them. And the bottom line which has come out is that we need a multi-sectorial coalition for people to think, promote education, capacity building, perform research, find data, extrapolate inferences of our own problems, not extrapolate data from abroad. Find the real-time data which exists for us and then formulate policies. Find pathways and processes to intervene and stem the tide of rising menace of non-communicable diseases that are going to challenge the future of our nation. So, sir, you, Dr. Shahid Beg, my very worthy colleagues of Ministry of Health who are listening, the people from the Planning Commission, and the other allied institutions, PANAH requests you to find a common platform, create a multi-sectorial coalition for all the purposes that I've highlighted. That's the bottom line of today. Thank you very much.
Before I ask the chairman to sum up this session, I'd take this opportunity to give the shields to the speakers. And for this, I'd request the chairman, General Azhar, please come and give shields to the speakers who are present here. Dr. Shahid. Dr. Shahid. Dr. Shahid, sir. To give shields to the chairperson and the co-chairperson, I would request my teacher and mentor, Dr. Masood Kiani Sahab, to please come on the stage. To General Azhar, sir. Dr. Manzoor. And to myself. I request General Azhar to come and sum up the session.
Bismillah ar-Rahman ar-Rahim. I think all of you are tired. Yeah, half of you must be sleeping. And rest they were seeing their mobiles. I was watching. First thing I want to tell you, Riphah, PANAH, AFIC, they are one. Because in AFIC, PANAH was born. The pioneer of all these three, and even Hearts International, is General Zulfikar Ali Khan. So this is one family actually. And second thing, Junaid, I'm not going to forgive you. You were saying General Masood Kiani is my mentor and teacher. He is my mentor and teacher. We have an association of 42 years. I joined AFIC as a young captain in 2nd November 1980. General Masood Kyani was Lieutenant Colonel. He was head of the Department of Cardiac Surgery. And since then, he has groomed me. I was a very bad boy. So he groomed me very well. Coming to this session, वो एक ओए बंद करो किसका बोल रहा है? There was a man went to a doctor. He was not well. He said, okay, stop this, stop this, stop this, stop this. उसने कहा मैं फिर जिंदा किस लिए रहूंगा? तो आज तो ये सब कुछ बंद करवाने हमारा इधर. लेकिन coming to this point, I'll come later. Let's talk some good things. Average age is increasing. Where it was about 200 years ago, 40, 45. It's in Pakistan, even it's around 67, and worldwide it is 75 plus, or in developed countries. And in the middle of the next century, they say in the developed countries, it will be 150 years. Good or bad, think about it. And there is more awareness of the health. Yes, the tummies are coming out. It's a sedentary life. But there are more awareness programs at an international level and a national level. So these are, and PANAH has done, I'm watching PANAH like I was in AFIC when PANAH was born. In the last 2-3 years, they have launched very aggressive attacks. And especially their attack on tobacco, in spite of a lot of resistance, they have been able to succeed in that quite a lot. And then now they have opened another front of NCDs. And I'm sure with General Masood Kyani spearheading the attack, they are going to achieve much more in that. Regarding this session, there are 3 things in it. It's a game of individual's choice. It is economics. And it's the game of the powerful. Nobody stops anybody, right? It is our health. It is our duty to take care of it. And if we don't take care of it, we are responsible for it. Everybody knows what is good and what is bad, right? All of you, the youngsters sitting here, seems के कम खाते हो, ये तो मुझे नजर आ रहा है स्वाय 1-2 के. लेकिन ये मुझे बताओ, एक्सरसाइज कितने करते हो? हाथ खड़े करो ना. मर्द खड़े हुए हैं, खवातीन में एक हाथ ऊपर, दूसरा गया, वो भी आधा. ठीक है ना? So choice is yours. So this is a game of the individual. You can take care. और ये गेम जो है ये आज से शुरू नहीं हुई, हजरत आदम से शुरू हुई है. अल्लाह ताला ने कहा ये करो, उन्होंने उसका उल्टा किया. उन्होंने कहा फिर निकल जाओ जन्नत से. और आज तक इंसान वही करता है. Defiance and curiosity is the nature of a human being. और उसको अकल कब आती है? जैसे मुझे आई जब मुझे स्टेंट पड़ा. ठीक है ना? सो आप लोग अभी जिस एज ग्रुप में हो, kindly look after yourself. दूसरा, it's a game of economics. The governments, they are subservient to those who run the economy, the industrialists. Whether it's United States of America or Pakistan, it's the same game. And these industries, they contribute towards national exchequer. They are having a bad effect, but to counter them is not at all easy. And also, a great threat is aging. At the age of 80, 85, there is a knee replacement, there is a lens, there is a stent, or you have undergone a bypass. One person is eating 6-7 medicines, so health budget goes up. So if the age increases to 150 in the middle of the next century, what's going to happen? So human being will decide when a human being has to die. So maybe for the governments, it's good that they are having a junk food. They are having fizzy drinks. They are smoking, right? So they will die early. It's going to save money for them. So we have to find, if we want to curtail it, we have to find a better alternative. That is very important. And how to go about it, it's a big challenge. Governments will say, keep on saying, this is bad, this is bad, this is bad. They won't do anything because they are running their country because of that, and everybody needs money. So this is another challenge which is there, definitely. And the third thing I talked about, I've already talked, is the game of the powerful. That those, when we are, our parents are paying for us, we are under them. जब इंडिपेंडेंट हो जाते हैं ना, जिन्होंने पाला होता है उनके आगे खड़े हो जाते हैं ना, ऐसे ही है ना. लेकिन जब तक वो पाल रहे होते हैं और जिस मेहनत से पाल रहे होते हैं वो समझ नहीं आ रही होती, तो वो आ जाती है बाद में जब खुद आदमी ही पेरेंट बनता है. सो the powerful is the one who runs the show, and the one who is running the show, nobody is going to harm them. So this is a great challenge, but it's very commendable that PANAH, in spite of very meager resources, I know, and very small workforce, they have taken a giant leap into it. They have, initially they were on the roads, doing marches in Murray, in Pindi, and somewhere else, and now they have been able to penetrate the corridors of power. So I would request, if anybody is listening from the government, that create better alternatives to counter these industries who are harming the health of our people, especially youth. They have become totally sedentary. They don't play in the fields outside. And one can have very simple things, like any residential area can have a big park with jogging tracks. All organizations can have gyms. And with the fast food, why can't we have healthy foods? But the issue is, the healthy foods are not tasty. They have to make tasty, healthy foods so that people divert, or especially youth. Middle age में तो थोड़ा अल्लाह याद आ जाता है, तो आदमी खाने में कंट्रोल करना शुरू कर देता है. लेकिन यंगस्टर आज का जो है वो ठीक नहीं है. So please look after yourself. That's all I have to say. And I think that's enough. Everybody is tired. I wanted to wake you up. I think you are all woken up by now. So thank you very much, sir, for honoring me and calling me here. So Riphah is always at your service. And here you said, but I must say, it is our Chancellor Hassan Muhammad Khan Saab. He directed us. He is son of General Zulfikar. And General Zulfikar's photograph is behind my chair in my office. He was my commanding officer for 11 years. So he's always watching me and I am shivering. So sir knows very well. So Hassan Muhammad Khan Saab, he directed us that it should be a very good function. And Brigadier Maqsood has done a great job. I don't do anything. I just tell people what to do. So it's all organized by him, and we are at your service. Whenever you tell us, मैं आखिरी खत्म करता हूँ. हम कार्डियक सर्जरी की पहली कॉन्फ्रेंस करा रहे थे पाकिस्तान सोसाइटी ऑफ कार्डियोवास्कुलर एंड थोरेसिक. उससे पहले भी 1 साल पहले हमने कराई थी पाकिस्तान सोसाइटी, तो सर उसको लीड कर रहे थे. मुझे कहते हैं कि ये करानी है 6 महीने में. वो इंटरनेशनल कॉन्फ्रेंस इज नॉट इजी टू ऑर्गेनाइज. मैंने दूसरी तरफ देखना शुरू कर दिया ना, तो मेरा ख्याल था कि आई विल शो माय रिजेंटमेंट तो थोड़ी देर में सर ने कह रहा था फौज के अंदर कब आप छूट थोड़ी सकते हो, तो सर कहते हैं ये करानी है। तो वो 6 महीने में इतना प्रेशर था कि तबीयत साफ हो जाती है. इट्स नॉट इजी टू रन ऑल दीज शोज, एंड आई थिंक Pakistan Science Foundation has taken a great step. Sir, must appreciate your help and support, and I think it will be there forever. Thank you very much.